In a session of today's recording and PDF slides will be added to NAHU's website, hopefully within 1 week, but it may be a little longer than that depending on how we can get it processed or when we can get it processed. Throughout today's session, please use the Q&A pod to ask your questions. The speaker will address them at the end of today's presentation. And I'm going to ask Dr. Egan to skip to the next slide, please. So today's presentation, very similar to the presentation from a couple weeks ago. Today is a collaboration between NAHUD ORN and MATEC Kansas, Nebraska. So a little bit of background on NAHUD, or the National Alliance of HIV Education and Workforce Development. Their membership organization of 8 regional and 2 national AETCs, and their mission is to increase access to reduce disparities in and improve quality of HIV care and service delivery through workforce development, education, TA assistance, and advocacy. And if you'd like more information on NAHUD, please visit the NAHUD website. Opioid Response Network, or ORN, NAHUD has been funded by the American Academy of Addiction Psychiatry as a partner organization of the Opioid Response Network to address intersections of HIV and opioid use disorder. And like NAHUD, it was created to support efforts in addressing the prevention, treatment, and recovery of opioid use disorder. If you would like more information on ORN, please access the websites, and I will be sure to put these websites in the chat in a little bit. Next slide, please. So just for a disclaimer, a little bit about MATEC. MATEC is a publicly funded training center providing clinical training and support to healthcare professionals. We are supported in our works through multiple grants and contracts in 10 states. And this is just a disclaimer letting you know that we are funded through HRSA, and the views do not necessarily represent the views of HRSA or the government. The views in this presentation, do not necessarily represent the views of HRSA and the government, but we just wanted this disclaimer here. Next. And this here, I'm not going to read it in its entirety, but this is just a MATEC statement on equity and inclusion, and it is just to let you know that we are trying. Our commitment to you is that we take this stance seriously, and we invite you to do the same. As we grow and evolve, we welcome you on our journey. From the great Dr. Maya Angelou, my mother used to say this to me all the time when I was younger: do the best you can until you know better. Then when you do know better, you do better. So that's what MATEC is standing by. Next slide, please. Oh, now I'm going to turn it over to Susan Tusher from MATEC Kansas, Nebraska, who is going to introduce our speaker for today.
Thank you, Ashley. Yes, I am pleased and privileged to be able to introduce our speaker today. Dr. Colleen Egan is an assistant professor in the Department of Family Medicine and Community Health at the University of Wisconsin-Madison, and the Associate Program Director for the UW Addiction Medicine Fellowship. She provides inpatient and outpatient care across a variety of settings in Madison, Wisconsin, and teaches fellows, residents, and medical students on a daily basis. She attended medical school at the University of Chicago Pritzker School of Medicine and completed her residency in family medicine at University of San Francisco. She's board certified in family medicine and addiction medicine. Prior to moving to Madison, she was a primary care provider in San Francisco, working for the Department of Public Health for 9 years, where she provided HIV care to individuals living with HIV and substance use treatment within the primary care setting to her patients. You're in for a wonderful presentation today, and with that, I will turn it over to Dr. Egan.
Thank you, everybody. I'm Kelly Egan, Colleen, when you look at my name on the slide, but I go by Kelly. Just a few disclosures. I don't have any financial disclosures. I will at the end of the talk mention a few off-label uses of medication, and that's only because there are no on-label medications for some of the conditions I'll be talking about. but I'll be clear when that is the case. Hold on, trying to get it to forward. There we go. My objectives for today are to define the levels and types of care that are available for treatment of substance use disorders. That's what SUD stands for. To review pharmacotherapy approved for the treatment of these conditions, including some pearls about outcomes, regulatory considerations, and then clinical pearls. And I recognize many of you are not prescribers and don't prescribe these medications. And I think there's value in knowing what's available, both because sometimes patients will come to you saying, I'm taking such and such, or I'm thinking about taking such and such, or maybe they really don't know there are medications and options. And so it can be an opportunity for some advocacy and to have a better understanding yourself and what they might be talking about. I will also be working to understand barriers to accessing treatment for people with HIV and AIDS who live in rural communities. And then lastly, to identify educational resources that are available to learn more about kind of everything I've been talking about. This is the second part of a two-part series. In the first part, I reviewed more about definitions, epidemiology, and kind of laid out the scope of the problem we have when it comes to substance use and addiction in our country, including among people with HIV and AIDS, as well as in rural communities, and then the overlap of all those things. So a real brief review is that, what is addiction? So this is a definition put out by the American Society of Addiction Medicine. And it's actually kind of uncanny that I'm going to read this because I just finished clinic this morning. I work at an HIV clinic here at my hospital, and I take care of people who use substances. And I saw a gentleman who yesterday got discharged from a 30-day substance use treatment program. And when I asked him, what did you learn in the last month? The first thing he said was, I learned that addiction is actually a chronic disease and it's not just my fault. And I think that was very freeing to him, and also provided some hope, because it took away, it really is, it's a treatable chronic medical disease that involves complex interactions between the brain, the genetics, the environment, and then of course one's life experiences. People with addiction use substances or engage in behaviors that become compulsive and continue despite harm. And that compulsion and continuation despite harm are hallmarks of addiction. But the good news is, and as this man was reflecting to me, prevention efforts as well as treatment are generally as successful as those for other chronic diseases. And so sometimes people say like, oh, that must be depressing work you do. And in fact, it's kind of the opposite, because I see such tremendous change in all sorts of ways. And so it really is, there is a lot of options. The clinical diagnosis we use is a substance use disorder. So this is, these are 11 criteria laid out by the Diagnostics and Statistical Manual of Mental Disorders, or DSM-V, and lumps basically 4 categories: impaired control, social impairments, risky use, and then pharmacologic effects of using substances. And to make a clinical diagnosis of a substance use disorder, which is really our clinical term for addiction, you sort of assess someone on these criteria, and then it can be graded as mild, moderate, or severe. I like this slide, and I need to give credit to my coworker, Dr. Salisbury Ashar, who works here at University of Wisconsin with me. But SAMHSA lays out a model of recovery. So treatment and recovery is never sort of singular in its path. You don't just take a medication and suddenly like everything is different. There can be significant change from a single intervention, but really it's multi-pronged. We think about health, we think about home, both, having some sort of housing, but ideally I think like I always think of the term as home and house as being very different. Home to me implying a place that's associated with more positive experiences and truly feels like one's own. So a roof over one's head isn't always adequate, but there's all different types of housing, and many people do struggle without housing who use substances, though surely not all. A sense of purpose. I had another patient this morning who told me like he really liked when he used to volunteer, and he was kind of sad that he wasn't doing that anymore. And purpose can come in terms of rekindling family relationships, volunteerism, getting back into the workforce, having things like art that bring you pleasure, but sense of purpose is really important. And then lastly, community, that can take many forms, but having a sense of community to support. So I think these are all important elements to think about when putting together a treatment plan for somebody and helping to talk to clients about to support their recovery. The treatments for substance use disorders sort of fall into two big buckets: behavioral treatments and pharmacotherapy. I'm a physician, so I think a lot about medications, but surely it's not all. I'm not as well versed in some of the behavioral treatments as my behavioral health clinician colleagues are, but I'll do my best to at least lay out a bit about them. In terms of the medication piece, there are FDA approved medications. So the FDA is sort of our licensing or regulatory board that approves medications for certain disease states. And we have meds for opioid use disorder, alcohol use disorder, and tobacco use disorder. But we don't have medications for many of the other substances that are used, including cocaine, methamphetamines, cannabis, plus others. This reference in the kind of gold box at the bottom is a great reference. It's the clinical HIV clinical guidelines for adults and adolescents, and has a section on substance use disorders and HIV. Talks a lot about the overlap, some of the drivers that can go both ways, which I addressed in the last talk to a degree, and also goes into more details about treatment recommendations. So as a reference, it's just good to have. So in terms of behavioral treatments and psychosocial supports, this can look in so many different. This looks different in many ways. And there are some evidence, there are some treatments that have a stronger evidence base for them. There are other realities, especially when we think about rural communities, in terms of, well, what's available? Like there can be things that that would be ideal, but there's nothing like that in my community. There's a shortage of providers, or my insurance doesn't cover it. So in some ways there's some realities, and these all can provide great value. So there's supportive counseling, which there's different sort of approaches to providing supportive counseling. One of the most evidence supported types is called cognitive behavioral therapy, and really sort of using our thought to understand our behaviors and how we can modify our behaviors. For people who use substances, a lot of times this looks like trying to understand how we cope with stressful situations and how we can change our behaviors. And why we use substances and what we can do to not use substances if that's one's goal. But there are countless other types of psychotherapy. And, I think there's also to be said the importance of having a therapeutic relationship with somebody, regardless of what type of therapy they offer. So if you can find a therapist or a counselor who connects with a client, that is worth its weight in gold. There are formal substance use treatment programs. I'll talk a little bit more about this, but they range in intensity, and there's something called ASAM levels of care that will be addressed in a future slide. There's something called contingency management, which I'll also talk about more. This is particularly well studied in terms of being an intervention to treat methamphetamine and cocaine use disorders, for which, as I said previously, there's not a medication for. And then there are peer recovery. I talked about the importance of community, the importance of having people potentially with shared experience who you can talk to things about. And it's not for everyone to do peer work, but for some people, they find groups, whether it's 12-step or not 12-step, to be supportive to them. And then there's also something called peer recovery specialists or peer recovery coaches. These are individuals with their own lived experience who've had some degree of training and now work as coaches or navigators to help people as well. And they have their own experience. And I will say my clients tend to find them very, very helpful. So if you live in a community where that's available, it's a great resource. And then never to be discounted is addressing mental health conditions when they exist. It's almost impossible to parse out substance use from certain mental health conditions. And so if there's an underlying mental health condition, that needs to be addressed and treated in whatever way is appropriate. In terms of finding treatment, I work in Madison, but I do a lot of peer coordination for people who kind of get, brought in by ambulance or helicopter sometimes to Madison, but ultimately are discharging to their communities far outside of Madison, often in rural communities. And so, I don't know all the resources by any means, but these are some options. I often go to the county DHS website or the SAMHSA treatment locator, which you can search by types of treatment programs as well as location, and then filter down to what might be available. And then in Wisconsin, 211 is an option to call to get more information as well. So I mentioned the ASAM levels of care. This is something that was created to try to standardize the different types of care. And I do know too that it's often used, it's a standardized assessment. It's really frankly quite long. I haven't gone through a formal training to do it. I think people who work in substance use treatment programs, they often have a team that is trained to do these very detailed assessments. But the goal is to identify what level of care someone needs and where they would best be served, recognizing that sort of the lowest level of care that can achieve what's necessary would be ideal, at least from if nothing else, cost perspective. So the types of services I deal with most commonly are outpatient services. So that's less than 9 hours a week. A lot of times that looks like having a therapist or a counselor who you meet with weekly. There's then level 2, which includes intensive outpatient and partial hospitalization. So this is where you're not living or staying 24 hours a day at a facility, but you're going for a far much greater intensity than just like weekly or twice a week counseling. And it's really defined by how many hours per week, but more than 9 hours for intensive outpatient and more than 20 hours for partial hospitalization, but you're not there full time. And then lastly is residential inpatient services, which is where people are 24 hours a day, but not with sort of physician level support. And so level 4 is 24-hour care with the physician level medical services provided as well. I'll be talking more about treatments for use disorders, and many patients have use disorders. Again, that's that clinical term for addiction. But we're also facing an overdose crisis in our country. And there's many people who overdose who don't meet the criteria for use disorder, maybe aren't interested, or frankly, it's not really appropriate for their clinical condition to be in some sort of longitudinal treatment, be it behavioral health or medication, but they are also at risk for overdose. But the good news is there's lots we can do to prevent overdose. And that includes use of medications when appropriate, naloxone education or distribution, which I'll talk about again in later in the presentation. Syringe service programs. This is sort of colloquial called needle exchange as well. But that's the distribution of clean and safe supplies for people who are using to decrease the risks of infection and other complications from not using more safely. We also encourage screening for fentanyl. In my own clinical practice, I do urine drug screens and I find fentanyl and often share that back to patients who are like, whoa, I had no idea that there was fentanyl in whatever it was they thought they were using. We know that fentanyl is has riddled the drug supply, especially stimulants. But there are also things called fentanyl test strips, which recently were sort of reclassified, at least in the state of Wisconsin, to not be considered drug paraphernalia. So there's now sort of a legal option to distribute those, but fentanyl test strips are these little strips that one can actually use to test their drugs before using. And then lastly, there's the Good Samaritan laws. So that's the ability to sort of ask for help, like call 911 and ask for help if somebody overdoses or is in medical crisis without the fear of incarceration or legal ramifications. So getting on to talk about medications, and again, I'm trying to highlight some of the salient features that people might benefit from knowing, even if they're never going to prescribe. So we have 3 medications to treat opioid use disorder. Those are methadone, buprenorphine, and extended release naltrexone. For all, the goal is to decrease a person's cravings to use opioids, to decrease or counteract the effect of the opioids. For buprenorphine and methadone, we're looking to decrease or eliminate withdrawal symptoms. And then for all of them, we're looking to basically help the patient to engage in treatment and recovery activities. If we can break the cycle of using opioids on a daily basis or many times a day, or at least frequently, it gives them space to start to engage in treatment and recovery. Now, if somebody is physically uncomfortable from acute opioid withdrawal, you can imagine it would not be very possible to sit through a counseling session and get much good out of it if they're focused on like their diarrhea and cramps and like shakiness that they're having from withdrawal. So these medications can really physically stabilize us to then engage. And then lastly, to support the brain's return to balance. When using substances, the brain is kind of constantly moving between intoxication and withdrawal. We know that things happen to the neurotransmitters and the circuitry in the brain. And so by stabilizing use and taking somebody out of the cycle of using opioids frequently, it helps to balance the emotional and decision-making pathways over time. These meds are different though. They have different effects at the level of the brain's opioid receptors. They have different sort of side effects. And then there's importantly some different regulatory considerations that I'll mention. And it's important to say, some people think about detox as treatment. Well, detox is not treatment. People can be detoxed or undergo detoxification, so to speak, meaning going through a period of letting all the substances, in this case, opioids, sort of wash out of their body. But we know for opioids particularly, if somebody detoxes and then is not connected to some sort of treatment, they actually have an increased risk of overdose. So that may mean medications aren't for everybody, but if they're not connected to some sort of treatment, be it behavioral or medication, residential, we know that they have an increased risk of overdose. And that's something we see frequently with people coming out of sort of controlled settings like incarceration, where they've sort of forcibly been detoxed over the course of weeks to months to years. And then when they leave, if they're not connected into treatment, they have more risk of overdose. That's just one example of that, not the only. Medications for opioid use disorder outcomes. So as compared to no treatment or treatment with placebo, we know that these meds can reduce illicit opioid use or unprescribed opioid use. They improve treatment retention, and methadone and buprenorphine decrease the mortality from opioid overdose deaths. And it is standard of care if you're a treatment provider to talk about medications. So some words about access, because access is really where we struggle. We know that tragically, over 70% of patients who have a diagnosis of opioid use disorder do not access medications. And this is for a variety of reasons. Access is especially limited in rural settings, and I'm probably preaching to the choir for those of you who work and live in rural settings and know that finding a treatment provider can be really difficult. You know, almost 40% of our counties across the United States have no data waived provider. So I'll talk about it later, but the data waiver is the special license that a provider needs to prescribe buprenorphine. And then almost 40% have no opioid treatment program, or quote unquote methadone clinic, as some people think of them, and they don't have a data waived provider. So essentially 40% of our counties, you can't get methadone and you can't get buprenorphine. We also know that only a third of substance use treatment providers offer methadone or buprenorphine. And so people might get confused by that statement. But I think what that is speaking to is that there's a lot of treatment out there different types of treatment that don't have the medication component. And the meds, as I said, are not everything and they're not for everyone, but they have some really powerful data behind them and they play a role in stabilizing use and helping people towards recovery. So there are a lot of behavioral health programs that don't have an affiliated physician who could prescribe these medications or other prescriber. And then there are some substance use treatment providers that sort of don't support the use of medications. And it is true that there is stigma towards the use of medications, both outside the world of addiction medicine and also inside the world of addiction medicine. And then some residential treatment programs actually prohibit the use of meds. And there's some, semi-valid, I would say, reasons for that. These are controlled substances. It may be very hard to coordinate having the staff to hold and safely store them. And so there are some real realities to why that is. But some patients can't get it because they're in a place where they're not able to access it. The good news is that primary care providers can prescribe buprenorphine, and they can also prescribe naltrexone, which, you know, we may have a shortage of primary care providers too, frankly, but at least we've got them all over the country, in all the counties in our country. And so if we could get more primary care providers to bring this practice into their work, we'd have better access. Access is also limited, and this is not unique to rural areas or people with HIV or AIDS, but access is limited by insurance, by language and cultural competencies, and by stigma as well. A word about where you can get treatment for these medications specifically. So there's something called OBOD, or office-based treatment, and that means, you know, sort of an outpatient non-specialty setting. So that could be primary care or sort of other similar types of settings. And you can get buprenorphine and naltrexone there. Can't get methadone. There's specialty care, so specifically addiction medicine clinics or psychiatry clinics. And those are sort of equal, you know, also quite accessible, maybe a little less so than within primary care, but they are outpatient. You're not going every day. And then lastly, there's what's called an opioid treatment program, or colloquial, some people still say methadone clinic. And that's the only place you can go to get methadone. Methadone has very strict federal regulations that I'll talk about. So methadone is our oldest med, approved to treat opioid addiction. At least that was what it's called back in 1972. So it's been around for a long time. And as I said, it can be only prescribed out of an opiate treatment program. People may have heard this and are kind of curious about it, but the federal regulations dictate that somebody must go every single day, or I should say 6 days a week, for at least the first 90 days of treatment. And so that's a lot. I mean, it amazes me when I talk to people who are able to do that. But you can imagine that if living in a rural community where you have a far commute to get to an opiate treatment program, the likelihood of being able to get there every single day is hard. If somebody's working, if somebody has childcare issues, if somebody has a physical condition that limits their mobility, this is a really heavy lift. And while some people progress to going less often, there's like a strict schedule that the federal guidelines dictate. If people have ongoing use of any sort, including, at least in the state of Wisconsin, ongoing cannabis use, which is fairly common, not universal by any means, they have to stay on those daily visits indefinitely. So I've met people who have been going daily for years, and that's pretty tremendous. And so it's one reason why people sometimes opt not to go to an OTP for methadone. Methadone is dosed daily, so it's once a day. And when a person goes to the clinic, they actually have an observed dose. They're given, it's a liquid, they're given liquid methadone and actually observed to have it. From the perspective of treating opioid withdrawal and opioid cravings, it's a very long-acting medication, so it can work for 24 hours, which is why you come once a day. But it's not going to be adequate for analgesia. Methadone can be used for pain, but when dosed daily, it doesn't help with that. So some patients with opioid use disorder live with chronic pain too. And there's a misconception that if you're on methadone at an OTP, that's your pain meds. Well, it's probably only helping your pain for the first 6 hours of the day, because we know it doesn't last that long. And then just for reference, sometimes patients will say, like, I'm on 150 milligrams of methadone. And people think, oh my gosh, that's a lot. Well, it would be a lot for somebody who's opioid naive or hasn't used opioids, but adequate doses, like doses that adequately control cravings and help people from continuing to use, typically range in about 60 to 120 milligrams. And many people require more than 120. Methadone reduces illicit or unprescribed use as compared to no treatment or placebo. We see increased rates of retention as compared to buprenorphine, though frankly, there's been follow-up studies that sort of question that and say that if buprenorphine is used at a therapeutic or a high enough dose, these are equivalent in terms of people staying in care over time. We know that being on methadone reduces HIV and hepatitis C transmission. There's been studies showing to decrease crime. And then we know, sadly, that leaving treatment is associated with an increased fatal overdose. Pivoting to naltrexone. Naltrexone is kind of the opposite. Naltrexone is an opioid blocker, an opioid antagonist. This is a injectable long-acting med that people get monthly. It's actually approved for opioid use disorder and alcohol use disorder. It comes as a pill as well. So you may hear patients say like, oh, well, I take the pill. The pill form is only approved for alcohol use disorder. And some nuanced reasons to why that is. It's the same medication, but it's just not approved in pill form for opioids. This medication can be available in primary care. It can also, naltrexone is offered at some opiate treatment programs. Not all, but some offer it. I think most people, why would they go there if they could get it in primary care or in a more accessible setting? And then with regard to outcomes, we know that it reduces opioid cravings by blocking the opioid receptors. It sort of helps to modulate the positive reward and euphoria that people get from using opioids. So helps to sort of control some cravings at that level. And then it reduces return to illicit opioid use, and it can help people stay in treatment when they're sort of on their therapeutic dose, if they're able to get onto it. So the pros are, some people really like this. I don't ascribe to this belief, but some people refer to methadone or buprenorphine as replacement therapy. It's not replacement therapy. It's not the same as continuing to use unprescribed illicit opioids. But some people hold that idea and they really don't want to be on an opioid agonist like methadone or buprenorphine. Again, it's more accessible because it can be prescribed in primary care. A lot of times this is the only type of medication that people can be on when they're in a treatment facility because of some of the logistic reasons I mentioned earlier about holding and managing medications in certain settings. There's no risk for diversion in terms of like a patient giving it away or selling it or anything like that because it's an injectable that you get in a doctor's office. And then it can be the right medication or a good medication for people who are dually diagnosed with opioid and alcohol use disorder because it treats them both. Though we don't have data to show that it's superior to buprenorphine. And then when somebody is on naltrexone, it very effectively is blocking the opioid receptors and will reduce one's risk for overdose while they're on the medicine. The cons, and this is the first one, is the big one, and where this sort of falls out and makes it not as popular or as common of an option, I guess I should say, is it can be really difficult to start. You have to be abstinent from all opioids for 7 to 10 days. And so for somebody who has been using, let's say, heroin every day for a prolonged period of time, to get to a full week without anything requires going through withdrawal, having uncontrolled cravings, and you have to kind of hang that out for a full week until you can successfully start this medication. And so in studies looking at like the effectiveness of this, a lot of times it doesn't look as good because people don't successfully get to that 7 days, and they don't even get to the point where they can get the med. They return to use or relapse sooner. It doesn't help with pain for people for whom pain is a problem. It requires coming monthly. So some people like that because they only come once a month. Other people like forget to come and then they fall out of care and then they can come back later and they're in this constant start-stop. We do know, and this is one of the big risks of naltrexone, is that while you're on it, you're not using opioids and the opioid receptors are all blocked in your head. And if somebody's on it for say a month or 6 months, they lose their tolerance to opioids. And so if they have been using 100 milligrams of morphine every day before they started it, they were tolerant, their body could handle 100 milligrams of morphine. They then get on the naltrexone, they're not using any opioids for a period of time, their body is no longer tolerant. And if they stop for some reason and they return to using opioids, they can't handle what they previously used. And so unfortunately, we see increased rates of overdose and death after somebody stops naltrexone, specifically because their tolerance drops so drastically. And then again, if on treatment and consistent with treatment, retention is good, but it can be really hard to start naltrexone. And so overall, people don't seem to be able to stay in it as long. Although if somebody successfully gets on it, they tend to be able to stay on it for a long time if it's working for them. And then lastly, buprenorphine. So this is what I prescribe most commonly, partially because I don't work in an opioid treatment program, but this is a partial opioid. So it's got a lot of the effects of opioids, but it has importantly what we call as a ceiling effect. And so you may have heard that the risk of overdosing on buprenorphine is very low or not there. And that's true. Despite doses getting higher and higher, we don't see it continuing to suppress the nervous system in the same way that higher doses of methadone or higher doses of other opioids do. And so I never say never that one can't overdose on buprenorphine, but if taken as prescribed, especially in one of the, like within the range of what we prescribed for this, the risk is exceptionally low. And cases where buprenorphine has been found in overdoses tend to be in conjunction with other depressants such as alcohol, benzodiazepines, perhaps sort of injecting buprenorphine in attempts to misuse it. It's a tremendously safe medication and also life-saving. It was approved in 2002, so quite recently. It's available in primary care as well as at OTP. So people call them methadone clinics, but almost all OTPs now offer buprenorphine and methadone. It requires a special waiver to a provider's license, which I'll talk about a little bit in the future. It can be prescribed by physicians, nurse practitioners, physician assistants, midwives. So there's sort of a whole host of types of people who could prescribe this medication. In theory, it's prescribed once a day, but we know that a lot of people have benefit from taking it twice a day. So maybe they have their dose split. And people with pain in particular are people who I recommend and consider splitting the dose, because buprenorphine is a fantastic pain reliever. You may need to use a higher dose for pain control than just for controlling cravings or withdrawal alone. But people that have struggled to get good pain control in the past, especially for whom using opioids for pain is not a good option, sometimes do really, really well on this if their dose is split 3 or 4 times a day. There's, years ago, there was sort of requirements and belief that people had to be in counseling. There's actually been studies that show there's no difference in outcomes when there's counseling or people don't have counseling. I always encourage counseling if people want it, but I would never withhold prescribing because somebody's not interested in any sort of counseling. And then similar to methadone, we see reduced rates of illicit opioid use, increased retention and care, decreased risk factors for HIV infection, and that it's very effective in primary care. I think it's important to talk about buprenorphine-naloxone just because there's so much misconception about this. So when patients say they're taking buprenorphine, they often use the term Suboxone or subs because that's the most common brand name. And if you see the wrapper or you read about it or you hear about it or the patient tells you, it's actually 2 drugs in one. So buprenorphine is sort of what we're using to treat opioid use disorder, but it's formulated with naloxone included in the medication. These come as films or tablets, but regardless if it's a film or a tablet, it has to be dissolved and absorbed under the tongue. That's what sublingual means. It's never swallowed. It won't work if it's swallowed. So why in the world is there naloxone in it? A lot of patients, as well as other people, even in the field of addiction medicine, think that naloxone is in there to prevent an overdose because naloxone is an opioid antagonist or a blocker. And so if somebody was using heroin and took naloxone, it would reverse the effect of the opioid or put them into what's called precipitated withdrawal. So immediately put them into withdrawal. Naloxone is essentially, Narcan or the overdose reversal medication. When used sublingually, so when absorbed under the tongue, naloxone has no effect in the body. The reason that naloxone is included in these films and tablets is trying to be a deterrent to have people not inject or misuse their buprenorphine. So I really don't think there's a lot of this going on, but there was a tremendous amount of fear when buprenorphine was released as a treatment for opioid use disorder that people were going to try to misuse it. If anything, I think buprenorphine on the street tends to be diverted for the purpose of other people treating themselves. But if buprenorphine naloxone were injected, then naloxone would cause precipitated withdrawal. But the naloxone does not cause withdrawal. It's not going to take away the effect of somebody's opioids if they continue to use. So there's a lot of misunderstanding, and then people are fearful to be on the medication at all because it's got an opioid blocker in it. So the waiver that I mentioned in 2000, there was a act that legalized office-based addiction treatment. It laid out that a provider with a DEA license had to undergo 8 hours of training to get a special waiver to prescribe buprenorphine. And so this was a pretty big, and initially just physicians, and then physicians and NP, or physician assistants and NPs. But this has been a big, I think, deterrent. The fact that, there's no special waiver to prescribe crazy high doses of morphine, despite how dangerous that can be. There's no waiver to prescribe toxic chemotherapeutic agents. And this is a life-saving medication, but there's special training and a special license that needs to be obtained to prescribe it. I think it's important that people responsibly and knowledgeably prescribe it, but there's some debate about this extra waiver that's required in terms of what that's done to our access. But in April of 2021, Health and Human Services actually sort of reduced the requirements. So people no longer need to undergo the 8 hours of training if they intend to treat less than 30 patients. And a lot of people in their primary care practices are treating a handful. So they fall in this category. I think it's a little weird that if you want to treat more than 30, you have to go through the training, because frankly, if you've treated 30 or 25, you probably have enough experience to know how to treat more. But that is how it is laid out right now, is that if you intend to treat more than 30, you have to then go through the original 8-hour training. There's lots of free trainings, online trainings that can be done. So this isn't the biggest barrier, but I think it's one of the many reasons, including stigma, that some prescribers shy away from having this be part of their practice. And then they also very clearly stated that referring to psychosocial services like counseling is not required. Of course, it can be optional, but it's not required. So patients ask me, other people ask me, how long am I going to be on these meds? Well, we know that with buprenorphine and methadone, longer treatment is associated with better outcomes. And discontinuing meds are associated with risk of return to substance use and overdose death. But if I go back to that original slide, SAMHSA's recovery model that talks about home, health, community, and purpose, when people want to stop medications, I often think about those 4 domains and how has life changed? What does life look like? What is some people like the term recovery capital? What are all the strengths that we have that support us in life that would make decreasing our dose of meds or stopping the medications possible, and we would continue to thrive. With regard to naltrexone, we also know that continued treatment is associated with better outcomes. To some people, that can sound like, oh my gosh, that sounds like forever. I don't want to do that. And, each case is individualized, and I take it slowly with time, with lots of discussion. But we do know that outcomes tend to be better with continued treatment. Pivoting to alcohol. So the good news is that similar to opioids, alcohol use disorder can also be very effectively treated in the primary care setting. Again, primary care isn't everything, but we've got a whole lot of primary care doctors in our country. This can look like sort of what's called primary care management has been laid out as consisting of counseling, prescribing of meds, and connection to behavioral intervention. So like referrals to a formal counselor or a treatment program. Briefly, medications in addition to primary care visits is really effective to reduce consumption and complications of use. For every 7 people treated, we can have significant reduction in complications and consumption. We know that meds can improve people's quality of life. And the good news too is that when they compared medications plus care in primary care, so meds plus meds in primary care versus medications with far more complex behavioral interventions, like say going to an intensive outpatient program 3 to 4 days a week, the outcomes are equivalent. And so it doesn't have to be the most intense, most complicated intervention to be successful. A brief intervention, which I talked about a little bit in part 1 of this talk, is the goal is to offer something brief. I mean, none of us have much time. And so, this can be done by a physician, this can be done by a counselor in various ways, but the goal is to reduce harm that's coming from the current level of use. These are short sessions, usually done a few in a row, 2 to 4, 5 to 15 minutes each. It utilizes the technique of motivational interviewing, which is sort of engaging and identifying a patient's goals to help them towards behavior change. And the idea is to be really concrete, to set concrete goals. By 2 weeks from now, I'm going to smoke 1 less cigarette a day. And so really time limited, concrete, attainable with close follow-up. And we know that brief intervention has strong evidence to support reducing alcohol use among people who are at risk or have mild or moderate use disorders. And then there's evidence that, there's sort of more gray evidence to support the use with other drugs. And then it's also been really called out that brief interventions really need to be culturally and language competent. So trying to do this for a patient who comes from a very different background, who may think about health and life with different values or in a different framework, really needs to be taken into account to be successful. So meds for alcohol use, we have naltrexone, acamprosate, and disulfiram. Those are FDA approved. And then there's some that have evidence that aren't FDA approved. I talked a lot about naltrexone before for opioid use disorder. This is that opioid blocker. And I want to wrap up pretty soon, so I'm going to go through it very quickly. But the big contraindication is you can't use this if you use opioids because it blocks opioids. We know that naltrexone can be really effective both for maintaining abstinence when that's somebody's goal, but also to decrease use. So for people who have a binge pattern of use, we know that over time they drink less when on naltrexone overall. Acamprosate is a 3-time-a-day medication. It has the advantage that it can be used in people that have severe liver problems, whereas naltrexone can't. We know acamprosate can increase abstinence rates. It's more effective in patients for whom abstinence is their goal, not ongoing but reduced use. And then lastly, there's a medication called disulfiram, which is the oldest. It blocks enzyme in our body that metabolizes alcohol. And so when you're taking disulfiram, if you then ingest alcohol, get really high rates of something called acetaldehyde, which basically causes what feels like a horrible hangover pretty quickly and makes people just physically very, very ill. And it's supposed to be like a negative reinforcement to not drink. Well, more recent studies have shown that we're pretty smart humans. I mean, we do a lot of stupid stuff, but we're also pretty smart. And people know that if they don't want to feel ill and want to have a drink, they just don't take the disulfiram. And so meta-analyses have shown that this isn't really effective over time. It sometimes has its place, especially in supervised settings where it can be given consistently to somebody. And there is an interesting antiretroviral consideration for this med. Again, it's not a med I use much anyways, but if there is any alcohol, it's not always drinking. There's medications that sometimes have a ethanol or propylene glycol solution in them. So some antiretrovirals have that. So this is just be something to consider if somebody's taking meds for HIV. And then also hand sanitizer, certain mouthwash, things like that. So people can get kind of unknowingly in a bind if they're taking this. And, now we all wash our hands with hand sanitizer all the time. So potentially problematic there. There's also some real toxicities, some danger for people with advanced liver disease, as well as some cardiac concerns. So I rarely prescribe this, but it is FDA approved. There's interest and evidence to support the use of these non-FDA approved meds, gabapentin, topiramate, and baclofen. For tobacco use, really briefly, we use nicotine replacement. So that comes in the form of patches, gums, or lozenge. And then there's 2 medications that are oral pills, bupropion and varenicline, that can be used. Both have good support. Varenicline sort of has the best data behind it. And there's no significant interactions with varenicline and antiretrovirals. The morbidity and mortality of tobacco is tremendous. And I will fully admit that I'm often focused on the harder stuff, so to speak, but we could all do a better job at addressing and supporting our patients to reduce or stop using tobacco. And then there's stimulants, which is sort of the $1 million question. And sadly, we don't have medications that are as effective as we do for opioids and alcohol. So behavioral treatments are our mainstay. Contingency management is sort of first line with data to support its use in cocaine and methamphetamine use disorders. This is the idea of getting a tangible benefit, usually monetary or some sort of gift or prize for evidence of doing something. And the way it usually works is people come in and give a urine sample, and if it's negative for the substance that they've been using, they get some sort of benefit. There's strong evidence to show this works while people are engaged in the contingency management program. There are a few places. I mean, the big problem here is funding. How does one set up and fund a program like this? Insurance doesn't pay for it. The VA system has done probably one of the best jobs. And then some places do this with grant money or other creative funding mechanisms. Cognitive behavioral therapy, again, one of the psychosocial modalities, has strong evidence to support it as well. But there's nothing FDA approved. There are some, again, medications of interest, mirtazapine, bupropion, and then buprenorphine-naloxone, as well as topiramate. And one of the really big things here is if somebody has comorbid mental health conditions, those should be treated, because untreated depression, untreated bipolar disorder, untreated psychosis can drive substance use, and then substance use drives those conditions as well. Some words about harm reduction. Harm reduction is the idea of reducing the harm associated with substance use. It does not, it's not opposed to abstinence. This isn't like a strict dichotomy. Abstinence is one thing along a spectrum. Harm reduction doesn't encourage drug use. It doesn't discourage drug use. It's really looking to reduce harm. And it's a really effective strategy. It's sort of everything we do is harm reduction. You know, when I drive in a car, it's dangerous. So I put my seatbelt on to reduce my harms if something happens. People wear condoms to reduce the risk of sexually transmitted infections with sexual intercourse. There's so much, I mean, life is harm reduction essentially. But it's been sort of, there's a lot of stigma towards it when it comes to drug use. It can look like safer substance use. So having safe supplies, safer injection practices, reducing risk of death using evidence-based treatment and naloxone. I mentioned naloxone earlier. This is the overdose medication. It acutely, so immediately will reduce overdose if somebody has too many opioids in their system and has stopped breathing or their central nervous system is depressed. Prescribe it always. Encourage patients to have it. I usually tell people, because they say, well, I'm not going to overdose. And I even said, somebody said to me today, if I overdose, I live alone. Nobody's going to give me this. And there's some reality to that. So if people have others in their life, encourage them to tell their friends or family about the medication, know where it's stored, know how to use it, which is most of the time just spraying it up their nose. It comes as an injectable too, but often a nasal spray. But people I carry it in my purse. And if I saw somebody laying on the ground outside the grocery store, I would spray it up their nose. And if they had a heart attack, I wouldn't hurt them. I would only potentially save them if it was actually an opioid overdose. And tragically, overdoses happen far too often in our world. So this is a life-saving medication. These are just the next couple slides are some really brief references to learn about harm reduction. If this is something you're interested in learning more, I think one of the best things we can do for patients is to incorporate harm reduction strategies into our care. And so these are some references to sort of look towards. And then some resources, just some resources that are affiliated, at least with my work. We run a full-time business hours, at least hotline that providers can call to get treatment recommendations for patients who use substances. We also run a monthly webinar called Project Echo Accept, Addiction and Comorbid Conditions, Enhancing Prevention and Treatment. That's the third Friday. And if you go to that link on the University of Wisconsin website, you could sign up for the newsletter and then be invited to every monthly session. So I think that is my last slide. I apologize that I really filled up the time.
No, it is okay. We do have a couple questions. So I'll read the first one. And it is, what medication can be prescribed for alcohol addiction?
So alcohol is the medications that are FDA approved are naltrexone, acamprosate, and disulfiram. And then there are definitely some others that are used, usually second line, and often sort of more nuanced decision making about what other conditions are going on. But
all right, thank you. The next question is, who can prescribe the medication? I'm guessing it's from the same person, so I'm guessing the ones that you just named. The general medical provider, or should it be a psychiatrist?
Yeah, that's a good question. So it could be either. So in terms of alcohol, psychiatrists can prescribe this, primary care providers, that includes nurse practitioners, physician assistants. And then if we're thinking opioid use disorder, those same people can prescribe buprenorphine and naltrexone, but somebody would have to go specifically to an opioid treatment program to get methadone.
Okay, great. One last question. Can you talk more about treatment for fentanyl use disorder? I have heard mixed messages about the effectiveness of buprenorphine.
Yeah. Fentanyl is tough. So fentanyl use disorder would fall under the category of opioid use disorder. And so the treatment options are the same: buprenorphine, methadone, and naltrexone. Anecdotally, and I think there's evidence in the literature too to support this, that patients who've been using fentanyl regularly, which is increasingly common because there's fentanyl in so many things, including heroin, often require higher doses of buprenorphine or methadone. I have many patients who've been using significant amounts of fentanyl and are very successfully treated with buprenorphine. But I've also seen some patients who just feel like even at the highest doses of buprenorphine, they still have cravings that aren't controlled. And in those cases, people have typically gone to methadone. You know, it's a hard decision to send somebody, sort of transition them to methadone, because that comes with just less flexibility. They have to be going to a clinic every single day. Is there a clinic accessible to them? Is that realistic? And then higher doses of methadone, when prescribed at the right dose, you know, shouldn't be too strong, but we also know that high doses of methadone have their own risks and side effects. Things like sexual suppression, sexual function suppression, bone, like osteoporosis risks, some like endocrine things. I wouldn't, you know, I still think that the risk of having untreated fentanyl use disorder far outweighs those potential side effects of high doses of methadone. But so essentially it's the same, and it's difficult. Some patients find that starting buprenorphine is more difficult if they've been using fentanyl. And I didn't talk at all about how one starts buprenorphine. But to start buprenorphine, traditionally, we wait for people to go into some degree of withdrawal, which can take on the order of 12 to 24, 36 hours. Some patients who've been using fentanyl find that that's harder. And so there are some creative approaches that providers use in terms of what's called low dose initiation, where people can continue to use fentanyl at their regular pattern. And then they start the buprenorphine at these very tiny doses over about a week until they get to a therapeutic level, and then people can more successfully transition. So it's far more nuanced. I don't know if that helps at all.
Great. Thank you, Dr. Egan. I believe that was the last question, unless someone wants to throw one in. If you can refer to the chat, I have dropped the evaluation link for today's session in there. If you could take a few moments just to complete the evaluation, we would greatly appreciate it. We are offering CME, continuing nursing education, as well as social work continuing education. And please allow up to 2 weeks for processing for those CE continuing education credits. And Dr. Egan has put her information up here to contact, and we will also post a PDF of the slides on NAHU's website. I also dropped in the chat some additional resources to the AETC website, the NAHU website, as well as MATEC's website. So feel free to access those as well. Thank you all for joining us. And if no one has any questions, you all enjoy the rest of your day.
Thanks, everybody.